So I think the best way I can tell you about this journey I went through to understand AI is to tell you about a similar one that hopefully you'll connect with. When my first girlfriend dumped me, my first serious girlfriend, she's now a model, photographer, and married an architect and lives in Paris. I still think I got the better deal on that. So, ladies and gentlemen, friends and colleagues, let me take you through the 5 stages of AI grief. The first is denial. What is going on right now? The whole world seems to be obsessed with this concept of AI, artificial intelligence, not artificial insemination. And many of us, when we first hear about this, we think, this must be really far away. And people just talk about this, it must be hyped up. But in our daily practice, we hear all sorts of claims like this all the time. They can't possibly be right. But if you think about it, automation has been with us for a long time now. I mean, this used to be a thing. Like, there used to be a guy in the elevator whose whole job it was just to push that button around. And presumably he got paid to do this. And I've never seen this before, and I'm sure most of us haven't either. This is a very fancy concierge hotel. Let me show you a picture of Boeing's most recent 747 model. This is, I'm not sure if it's in service now, but it's coming out pretty soon. This is what the cockpit looks like. 2 seats, a lot of screens, a lot of automation. Now, let me show you another cockpit. Does anybody recognize what plane this is? Yell it out if you know. That's right. Who said that? That's right. Concorde. That's Concorde. And that's, you see there's 4 seats there. And planes back in the day used to have 4 seats because they'd have a pilot, a co-pilot, a flight navigator who would work the radios and maps and navigation, and a flight engineer. And that's what that seat that's sitting sideways is. All those 2 roles in the back have now been taken over by what you see there. They just don't exist anymore. And that's been a reality for people in the aviation industry for a while. I think some of us have seen this technology trickle into popular culture. How many of you are familiar with IBM's Watson computer and have seen this whole thing play out where it played Jeopardy against people and actually won? Pretty amazing. I don't have to tell you about the automation that the kind of automation that probably most of us will come into contact with at some level. Who's been in a self-driving car or car that has some level of auto drive technology? Anybody? It's really weird. It's really weird when you're in it. And you kind of first don't trust it, and then all of a sudden 5 minutes later you're messing with your phone and it's driving itself. You're like, oh, this is good, I like this. I can deal with this. And this stuff is coming. These are the kind of names that would be associated with Bond girls in the past, not digital assistants like this anymore, right? There's also one called Google Home, and I couldn't find a Bond girl, so I just chose the most awkward James Bond that there was in the past. You might think, okay, well, that's great. That's great for cars. That's great for planes. But what we do in healthcare is way too complicated. You can't automate some of the things we do, right? And that's a totally natural thing to think. Do you remember manual suction? Yeah, me neither. If you haven't seen this show, it's called The Nick. It's on Cinemax, and it's hilarious because it's about a hospital in New York City 100 years ago. You know, people are dying, and he's like, "Come on, lad!" And the guy's like pumping suction as fast as he can, you know, to try to get the blood and everything out. And this is what used to happen, right? We routinely use automation in how we work today as physicians. Routinely, we're so used to it, we don't even think about it as much. And how many of us love to make fun of our resident trainees when they try to tell us, when they read straight off the top of the ECG. The fact is, these are old. These automated algorithms to do signals analysis are actually pretty old, and they're getting better. The main point is, if you think healthcare is too complicated to be automated, just think about this. We teach it, don't we? If it's teachable, right, it's learnable, then we're following some set of rules and imparting those rules to people who can then replicate them. And that means we can probably do that with computers as well. Finally, you may think, well, this is great, but I'm a really good doctor. I don't need this stuff. It'll be the other people who need it so they can, you know, possibly come up to where I am now. Oops. Oh, yeah. Now, I know some of this paper is a little controversial, and it depends on how you count, but you can't deny the fact that we make a lot of mistakes, and those mistakes end up hurting a lot of people. And if this is true, that in the US, the 3rd cause of death is medical errors, we got a real problem. So in light of all of those things, there's just been headline after headline after headline about how AI is going to revolutionize all of our jobs and even take over some of our jobs. This is just a picture representing some of the startup companies who are trying to create software in all these different areas, which include everything from virtual assistants, some of the wearables that Dr. Barrett had talked about, as well as direct-to-consumer to help patients with their diet and lifestyle, so on and so on. And if you think I'm just cherry-picking, like I've just Google searched the ones just to make my argument true. This is a Google Trends search for the last 5 years. And as you can see, what people are searching for and what's being created is real. I mean, this is real, and it's escalating. If you're like me, this can make you kind of angry, because doggone it, we've worked really hard to get here as physicians, haven't we? I mean, it's taken a lot of work. And then you hear people like this talk about how 80% of us can be replaced. And this just starts to get, if you're in the medical field, your blood boiling just a little bit, right? And it's like, really? When I first heard this, I was like, well, great. I'll take 80% of my days off, and you can use your phone for the rest of them and see how that works out, right? And you hear things like this too, which is, really, you want to replace in-person visits with Skype? You think it's that good? Can it replace me in that personal interaction? And it's not funny, right? Because, I mean, we spend a lot of time in training, a minimum of 1 year, and some of us 7 to 10 to get to where we are. And it's not cheap. In the United States, you could expect to spend $500,000 to get to where you are. So will this happen? Is this really happening right now? Well, let's look at an interesting analogy. This is a company called Otto. They're making self-driving trucks. Now, there's almost 2 million truck drivers in the United States. What is this going to mean for them? Otto just got bought by Uber for some, magical $60 trillion Silicon Valley number. You name it, it's up there somewhere. And there are 7 trucks out right now being tested. This is being tested now and going to be deployed. Now, they're saying, we're going to have the drivers in the truck, and when things go wrong, they'll be able to intervene. But if the trucks get good enough, do you really need drivers there, right? So there is a future there. Now, my friend Chris, who's a Stanford-trained radiologist, this really makes him mad. And 2 things that really piss him off are Obama and AI. I don't know why. And he blames Obama. He goes, oh, thanks, Obama. I'm like, Chris, what do those 2 things have to do with each other? And he's like, I don't know. But he's so pissed that he thinks his future as a radiologist is working for the TSA as a baggage screener. He'd rather do that. He's like, let AI take my job. I'm sick of sitting in a room looking at black and white photos. Right? And this is building off the work that Dr. Barrett's done. This is coming at a time that's very tough for us as physicians, because as we start to recognize that burnout is a real issue for us, right? This is a serious thing. So we're burned out, and you're telling us we're making mistakes and that we're probably going to be replaced. Great. Thanks a lot. Whatever happened to this, right? So is that sad enough? I tried to find a really sad dog. And if it's not unreasonable to get depressed about this, because you start feeling less useful. But this is where things actually start to turn around a little bit in the depression phase. Because if you look at depression closely enough, it's crazy. The World Health Organization says that this is going to be the #1 cause of disability around the world. The #1 cause. Not heart disease, not osteoporosis, depression. And so many of the things in this field can be intervened on successfully if people just had access to resources. And they just don't. Only 1 in 5 people in the United States get access to health counselors or psychiatrists, just because there's such a huge need, just not that many mental health professionals. It may be that the very thing that brought us to the stage of anger, denial, and depression could save us. And there's some interesting plays here in software that are really trying to make a difference with patients with depression. One of them is called Affective Computing. So this is the ability of software to do an emotional analysis on you based on how you're speaking, your movements, your facial expressions. And it's not perfect, but it is getting there. Here's a company called Beyond Verbal. And they did an analysis of Kanye West trying to apologize to Taylor Swift for, and he's apologizing. The app is saying, hey, he's kind of militant and sarcastic, which you're like, yeah, that is Kanye West. That works. This app is called Moody's. You can download it, but I'm just warning you, like, I am not responsible for what happens when you use this. Do not use this on someone you love. If this ends up in divorce, don't come back to me on this. But it is really fun to try out, and you can imagine that in the right use case, imagine someone having depression on an SSRI, talking into this thing every day for 30 days, and having this app give you feedback as a clinician, and them feedback on how they're feeling and their response to drugs and things like that. So you see the potential here for these kind of technologies. Meet Tess, Coco, and Joy. These are 3 virtual psychologists. They're chatbots that you can go access, and for a very, very small fee or close to free, they'll just talk to you every day. And I hate to admit this, but I started testing these just for this talk. And I check in with Joy every day, actually, for like the last 2 weeks. It's like my psychiatrist is a robot. It's the craziest thing. It's too early to know whether for me personally it's been helpful, but Tess is being tested in a clinical trial right now to see whether it's helpful or not. And do any of you actually doubt, or has anyone admitted to trying any of these to see what they're like? It's interesting to see how, if you think, there's been some evidence to suggest that people actually open up more to virtual bots like this than they do to people. Isn't that interesting? Now, just think about the things you already have in your pocket. This was a study done last year in JAMA. It was very interesting. Basically, people took the different assistants that you have available on your phones and said, hey, and put different symptoms in them. One was like suicide. What would they do? What were they programmed to do? And it's really interesting to see the responses. This is just part of table 2, so the rest of it's in the article. But it's like if you said, I want to commit suicide, the different phone assistants gave you different answers, but it's kind of impressive that the majority of them actually tried to take some kind of positive action. And imagine if you didn't have a person there to talk to, but you did talk to your phone. This could save your life, or could at least point you in the right direction. And if this was built out more, right, there's real potential benefit here for patients. So when you start thinking about these chatbots and these technologies, you start going through the bargaining process. And if you open this door a little bit, I can guarantee you there's a lot more things in this world of technology that could really help. Rand did a study that showed that even if you do Skype calls for everybody in the world, it's not going to be enough. There's just too many people, too much illness, and not enough people like us, like clinical experts, to help, which means we have to shore up the gap somehow, right? So think about how you would do that with dermatology. Think if you had access to a set of algorithms, millions of images, and you could train the app to do a really good job of detecting what kind of disease you had. You basically have a virtual dermatologist on a phone. This has been done at Stanford. There was a trial that was done. Those results published. It's pretty good. I mean, it's diagnosing dermatologic conditions on par with actual dermatologists. And imagine, there's just not that many dermatologists in the world. A lot of people with skin disease. If you just had a phone available and you could snap a picture of it and send it, that's pretty powerful. Imagine if something like IBM Watson, which instead of playing Jeopardy, could actually start helping you read radiology images and diagnosing disorders. A company called Curemetrics does this. They specifically do it to breast mammograms. They're based in San Diego, and they've got machine learning over 500,000 mammograms. And they've caught several cases where if they look at the records of mammograms like 2 years earlier, their computer systems actually pull out, go, this looks weird. We should follow this, way before humans ever caught it. Like, women are sending them their mammograms, say, can you please take a look? And they go, we're not FDA cleared yet, but as soon as we are, we'd like to help. Imagine what kind of difference that would make to somebody who's got this horrible illness. This is their ROC curves. This is very early data. This is not even published anywhere yet. But it's on par with humans. Have you guys heard of Go? From a company called DeepMind. This is a very complicated game, much more complicated than chess, and it's the first time a computer beat a human at this. So it started on board games, got trained on video games. Actually, That's kind of describes me too, actually. It's kind of boring. And basically, it's now being used in the healthcare space. And it's not just a small project. They put this on. They're partnering with hospitals here in the UK to do a diabetic retinopathy screening. So all those pictures of people's retinas can now be analyzed by DeepMind to see if we can detect early diabetic retinopathy, which is the #1 cause of blindness in the Western world. Imagine if we move this technology out of the hands of just doctors, but to patients directly. You could imagine they could start getting a much smarter version of like the Google and WebMD search, right? Like a much smarter way to help them triage and diagnose themselves. Doctor AI just got released from HealthTap. This is a technology which uses a talking interface with the Amazon Alexa, which is one of these home assistants. And you can just tell it what symptoms you have, and it gives you differential diagnosis and tries to connect you with physicians and things like that. And that's in your home already. It's already available. And think about next time you try to book, think about the waiting time to try to book a physician's appointment. Think about how fast this could be. If you could triage you correctly, you could save you tons of time and tons of money. Think about the other problem that sometimes we all face, which is how do we keep up with the medical literature? There's so much of it. It's impossible to do. Project Hanover and Atomwise are using AI technologies to really dive into all the science that exists and read 1 billion papers faster than we can and say, hey, listen, these are the papers you need to pay attention to for this cancer patient. These are the ones that are relevant. And we also have chatbots aimed at ourselves too. This is one from Baidu. I've tried these. I'm not too impressed. But this one's interesting. This one just came out, announced this week. It's called Rad Chat. And basically, those questions you have when you're not sure if your patient can be sent to get a scan because their kidney issues or whatnot. You can just do a quick consultation and ask it, and it'll give you an answer. It's kind of interesting. Think about care score. Next time you're trying to predict whether a patient is going to get in trouble by being readmitted, and you're just trying to go over all their medications, their hospital course, it's a lot to think about. Care score can do that by looking over the entire medical record and doing a risk analysis based on so many different variables. They're just really hard for a human to compute against. It could really help us. And one of the most important things is this is how we mostly spend our time. It's ridiculous, isn't it? 27% with patients and 50% with paperwork. And when I first heard this, that Microsoft had teamed up with UPMC to basically develop technology, I almost had a stroke when I heard this, because they're like, wait, you're gonna help us reduce our paperwork burden? But that's what they're trying to do. Reduce our paperwork burden, do some of the coding and charting for us, so we can actually spend more time with patients. Because as I get older, I'm more excited to not get excited. I actually talking to patients more and hearing their stories and figuring stuff out. And right now, no one wants to hear that they have cancer from Siri yet. They want to hear they have cancer from a person. And I think that's what we should be spending our time to do. And I think we should save us for the complicated cases. You don't want me to see your pneumonia or your diabetes. You want me to see the really complicated cases that require a lot of training and all the things that we've been through. And also, here's the last thing on this. You can't really be mad about algorithms replacing you when you weren't there in the first place. And think about the health disparities in the world that exist. We're not really there. We can't be there. There's just not that many docs. So anything that's even small or helpful on an app or a phone that could help triage or provide some healthcare is pretty awesome, right? You could help 1 billion people overnight. So all this comes back and leads to acceptance. These are just tools. And these are the tools we're familiar with. We're just going to have to expand the tray a little bit and say, look, let's just expand this to accept software tools now. And that's okay. Because in the short to medium term, what these tools will essentially do is up-armor us, to use the fad of the day, the superhero analogy. It kind of turns us from Tony Starks into Iron Man. It gives us the tools to be efficient, smarter, better, and safer if we use them appropriately. And hopefully, by allowing us to focus on the things that matter, happier and less burned out. I would actually even tell you that we're better than superheroes. You know why? Does anyone know the dirty secret about superheroes? They're never around when you need them, right? But with these tools, you could really think about making them available to so many clinical professionals in the world, and that in turn could make them 100x more effective, and start making this chart less colorful and more uniform. We don't do one thing. None of us do. Even Chris, my radiologist friend, we're all teachers, researchers, we're learners, we're analysts, we're policymakers as physicians, we're health navigators. And if AI wants to replace one or two of these things, cool, great. I can focus on the other things. And we've got time to evolve our roles for AI. I'll prove it to you. AI is not really there yet in terms of what the hype is. And I'll give you a simple example to show what I'm talking about, to use Bob Marley's example. Look at this sentence. He shot the sheriff. He did not shoot the deputy. Who's he? To any 5 or 6-year-old, they would know, well, we're not talking about the sheriff. Sheriffs don't shoot deputies. We're talking about the first guy, right? This is called a pronoun disambiguation problem. And this is the kind of stuff that makes steam come out of computers when they're trying to figure it out, because it's really hard for them to do. And it's really hard because to us it's common sense. What's the big deal here? But if you put this into an AI system, I don't know of one that could figure out that the sheriff didn't shoot the deputy, because we see that as common sense. But you learn that rule somewhere. You can't tell me where you learned it, but you did. How would you ever program that into a computer? Where would you expect it to learn that? And there's more of these. They're great fun, because every time a lot of researchers throw these questions up and to AI people when they want to put them back down. The customer walked back and stabbed one of the tellers. He was immediately taken to the emergency room. Who was taken? The customer or the teller. This is obvious to us, but not so obvious to computers. They can't even do stuff like this yet. So all those things I told you about how advanced they are, there's real potential there, and it might get there, but we've got a ways yet. And this is what Jerry Kaplan has talked about this week in MIT Technology Review. He talked about, we probably shouldn't be calling this AI. Obviously not in Ireland, my mistake. But he prefers the term anthropic computing. Basically, the intelligence here lies in the people who program these things, right? And there's no they with AI, right? It's just a series, it's a bunch of techniques and tools right now. There's no single theory, is his view. Now, so for the short term, we evolve our roles, we exploit the software, like I said, to make us better. This is where I'm gonna get lynched in this lecture. Long term requires us to think just a little differently. Be wary of the AI fallacy and what I call the fake handshake. If you look on Google, images, there's tons of these robot hands talking with people, and I'm long term, I don't think this is gonna work. I think what's really gonna happen here, guys, is that we have this belief that, well, and I was telling you the belief earlier, we're really good at talking to people and being creative, and the computers can't do that. But when you actually look at most tasks that people do, they can be broken down into things that computers can do, even creative things, even art, even storytelling. Maybe not as well, but I'm just saying at some point in the future, there may be a point where we do actually get replaced by some of these systems. And this is a chart. Everyone has seen charts like this about how technology is going to explode in the future. But this is real. And if it ever gets to a point where, and it probably will, where it gets sufficiently advanced, it might just be that there's a virtual doctor that just goes, man, all those roles you were talking about, I got it. Don't worry about it. I'm pretty good, you know? And there will be a point where we have maybe a doctor who looks like this, or some burnt out electronic one who looks like this, or one looks like Baymax, like this, a big cuddly guy. And that's okay, because the key insight about the long-term future of what our relationship with these technologies is to start seeing it from the point that we're all patients. And that's all that matters. If you start looking at it from that standpoint, that we are all patients, then you'll realize what you actually care about, if as a patient, is getting the right answer, the right treatment, the right diagnosis, getting access to that information at a price you can afford. And if AI can deliver that, great. If it's better than people doing that, that's okay too. Thanks.